Welcome to another deep dive, and this time we're tackling a cornerstone of plastic surgery, breast augmentation.
Yeah. Always evolving, always fascinating.
It is. So we're dissecting those advancements,
Yeah.
focusing on the implant choices and those potential complications that we all, as surgeons, need to be on top of.
Right. Well, thinking about how far we've come, it's amazing to go back to that very first breast augmentation in 1895 using a lipoma. Can you believe it?
Wow, a lipoma. That's incredible.
Really highlights the journey to the modern silicone implants that, we use today.
It does. And of course, patient safety, always top of mind. I mean, you can't talk about this without thinking about the FDA moratorium on silicone implants back in '92.
Absolutely.
And then, of course, lifting that moratorium in 2006.
Yeah. Pivotal moment for sure.
Huge. So what were some of those key research findings that really led to silicone implants making that comeback?
Well, I think the moratorium, if anything, really pushed for, rigorous research into the safety of these implants.
Yeah.
And those large-scale studies ultimately show, they demonstrated that silicone implants, weren't linked to, connective tissue diseases or any other systemic illnesses.
Well, that was a huge relief, I would imagine, for, I'm sure a lot of patients were concerned.
Absolutely. That coupled with the advancements, the improvements in implant technology really just paved the way for their return.
And speaking of those improvements, we've seen like 5 generations of silicone implants now.
We have. It's pretty impressive.
So take us through that evolution, generation by generation. What did each one bring to the table? What were those key improvements?
Each generation, really, it's about refining things.
Mhm.
The shell thickness, filler viscosity, the overall design of the implant. Think about the first generation. They had those thick shells and thick filler.
Yeah.
And that, led to those higher capsular contracture rates we were seeing.
Right.
Then you had the thinner shells, but then those had a higher rupture rate. So it's really this continuous improvement, each generation learning from the one before.
Right. Learning from the mistakes.
Exactly.
So if you had to break it down, what are those key characteristics that, let's say, distinguish a 4th generation implant from a 2nd generation implant?
That's a great question. I think, for example, 4th generation implants, they have that highly cohesive silicone gel.
Right.
And that's what really significantly reduces the risk of gel migration and rippling, even if there is a rupture.
Mm-hmm.
And this is a major leap forward compared to those earlier generations, where gel bleed and migration, those were big concerns. And the shells themselves, they've become more durable, more resistant to tears, just really upping the safety profile.
Yeah, absolutely. So with all these advancements, how do we, as surgeons, how do we approach this very important decision, choosing the right implant?
Right.
Obviously, volume is a big starting point,
It's a huge starting point.
but what else comes into play?
Well, I think you have to find that sweet spot, that balance, between what the patient wants, our expertise, and, what's actually achievable based on their anatomy.
Right.
It's not just about putting in the biggest implant possible.
No. You hear about this high 5 system.
Right.
Is that helpful for determining that optimal implant volume?
The hi-fi system is fantastic. It
Yeah.
really takes it all into account. You're talking about the breast base with the unforaminary fold to nipple distance, the nipple to sternal notch distance, sternal notch to clavicle, and even chest circumference.
Wow, that's a lot of measurements.
It is. It's a comprehensive approach, but you plug all that in, and it spits out a scientifically based recommendation for implant volume.
So you're really, I guess, taking the guesswork out of it.
In a lot of ways, yes, it helps ensure a natural and harmonious outcome.
I like it. I like it. So let's switch gears a bit.
Okay.
Talk about those different filler types that we have available.
Right?
The classic saline versus silicone debate.
Yeah. Oh, the debate rages on.
It does. So break it down for us. What are the pros and cons of each one?
Okay. Well, with saline, you're talking about a sterile saltwater solution.
Straightforward.
It's simple. And one of the advantages there is that it adjusts to body temperature quickly.
Okay.
And if there's a leak, well, it's just absorbed by the body, no harm. But on the flip side, they can feel a little less natural.
Mm-hmm.
And there's a higher risk of wrinkling, that you can sometimes see.
Sure.
And of course, there is that possibility of complete deflation if a leak does happen.
Right, because it's just saline.
Exactly.
Okay, so then what about silicone?
Okay.
I know a lot of people praise it for that natural feel, but are there any downsides? What are the caveats?
Well, silicone does offer, arguably a more natural feel and appearance.
Yeah.
But there are a few things to consider. For one, that silicone gel, it's a bit slower to adjust to body temperature compared to saline. And if a rupture happens, there's a chance for some local inflammation, maybe even granuloma formation. But thankfully, the newer generations, those cohesive gel implants, have really minimized those risks.
That's good. So it seems like both options have their own, set of pluses and minuses. What about the surface texture of the implant?
Oh, that's a big one.
Textured versus smooth.
Yeah, huge considerations there. Initially, those textured implants were designed to reduce those capsular contracture rates, especially, if you're placing it subglandularly. The thought was that the texture would actually sort of encourage tissue ingrowth, anchor the implant better, prevent it from rotating or migrating.
That makes sense.
But then, research throws you a curveball. Recent research has shown a potential link between those textured implants and that rare type of lymphoma, BIA-ALCL.
Right, yeah. Big topic, so we'll definitely dig into that a little bit later.
We'll get there.
But what about those smooth implants then? What are we seeing there, given this whole BIA, ELCL issue?
Well, smooth implants, they tend to have those thinner capsules. They feel less palpable. So they're really good, I think, for those patients with thin soft tissue coverage.
Okay.
But the trade-off is they do have, slightly higher contracture rates compared to textured, especially if you're going subglandular.
So it's really all about weighing those risks and benefits.
Always. It's about the individual patient.
It is. Okay. Before we move on to those incision options, let's just do a quick recap, maybe 30 seconds on what we've talked about so far.
All right. So we started by, going back in time, right? Tracing the evolution of breast implants from those early days to the sophisticated silicone implants we have now. We talked about those key things that influence our choice, the volume, the filler type, that surface texture. And I think the big takeaway is it's all about finding that balance between what the patient wants, our expertise, and really understanding those potential risks and benefits of each characteristic.
Absolutely. Great summary. Okay, so where do we make that cut? Where are those incision options for breast augmentation? And what are those key considerations when you're choosing between them?
So we've got four main ones, right? Inframammary, periolar, transaxillary, and transumbilical.
Okay.
Each one, of course, has its own set of, advantages and disadvantages. And the choice really comes down to, things like patient anatomy, where they want the scar, and your experience, honestly, what you're comfortable with.
Right. Okay, so let's break those down a bit.
Yeah, let's do it.
What are those specifics? I mean, what are the pros and cons? If you're looking at, say, an inframammary versus a periolar incision, what are those key considerations?
Okay, so with the inframammary incision, you're making that cut in the crease under the breast.
Okay.
It gives you great exposure and control, which is, especially helpful with larger implants.
Yeah.
And that scar, it's pretty well hidden in the crease, but it's still, it's on the breast. Now, the periolar incision, that's around the edge of the areola.
Right.
And that can hide the scar really well, especially if they have, darker pigmentation there.
Oh.
But you have to be meticulous, make sure you're not damaging those milk ducts. Could impact breastfeeding down the line.
Right, that's a big one.
Yeah.
What about the transaxillary and transumbilical when you're going with those less common options?
Okay, well, transaxillary, that's your armpit incision.
Yeah.
And the benefit there is the scar is totally off the breast.
Okay.
Which a lot of patients love,
Oh, okay.
But it can be tricky, especially with silicone implants.
Okay.
Visualization, control, a bit limited. So maybe not ideal for larger implants or those complex cases.
Makes sense. And transumbilical, I mean, that seems like a long way for the implant to travel.
It is. You're going through the belly button, right?
Right.
So the scar is completely hidden, which is a big plus. But you're usually reserving this for saline implants.
Okay.
It's tough to get that precise placement with silicone because of the distance.
Right. Right. So again, just choosing the right incision for the for the situation at hand.
Exactly. Tailoring it to each patient.
Okay, so we've got our incisions figured out. Now let's talk about where that implant's actually going. Pocket placement.
Yeah.
What are those main options that we have for that?
Okay, so we've got subglandular, subpectoral, and then there's the dual plane or biplanar technique that's becoming more popular.
Dual plane, okay.
Yeah. So let's start with subglandular.
Okay. Sounds pretty straightforward. Right under the breast gland.
Yep, right beneath it.
Okay.
Good projection, natural shape, especially if they have decent tissue coverage.
Mm-hmm.
But you do have a higher risk of that capsular contracture.
Right.
And it can be more visible, more palpable, especially if they have thin tissue.
Makes sense. So subpectoral then. How does that address some of those issues?
So with subpectoral, you're placing it partially or completely under the pectoralis major muscle.
Yeah.
And that gives you great coverage, especially for those thinner tissue patients.
Hmm.
And it can help minimize that animation deformity, where the implant moves weirdly when the chest muscle contracts.
Right.
But, it's not a perfect solution either.
No.
Sometimes you get a slightly less natural drop to the breast. And there can be a bit more discomfort, more pain in recovery because of the muscle involvement.
Sure. Makes sense.
So you have to weigh those factors.
So then dual plane, you said that was becoming more and more popular.
It is.
Kind of best of both worlds,
That's the idea.
combining subglandular and subpectoral.
Exactly. You're maximizing those benefits while minimizing the downsides.
Okay, so how does that work?
Well, you're placing that upper pole of the implant under the pectoralis muscle for coverage, right?
Okay.
And then you transition to a subglandular position in that lower pole.
So you get the best of both worlds. Yeah. The coverage and then that natural shape and drape.
I see. I mean, that sounds, I imagine that takes some pretty precise technique to get that transition smooth.
Oh, absolutely. You need precise dissection. Create that pocket just right. You have to release certain attachments of the pectoralis to get the coverage up top.
Right.
But you want to preserve that natural contour of the lower pole.
So it's a balancing act.
It is.
Are there different types of dual plane? Or is it just kind of one standard?
No, there are actually three main types, type I, type 2, and type 3.
Okay.
And they vary in how much of the pectoralis muscle you're releasing and how you position that implant in the pocket. It really depends on, the patient's anatomy, the implant itself, and what you're trying to achieve aesthetically.
Got it. So each type has its own, sort of specific use case.
Right.
Okay. Let's shift gears a little bit. Let's talk about, the actual surgery itself.
What are some of those technical nuances, those key pearls that you've learned over the years to really optimize outcomes and minimize those complications?
Oh, man, where do I start? I mean, it really comes down to technique, meticulous technique, and just, sticking to best practices. Perioperative antibiotics, those are essential.
Yeah.
Got to reduce that infection risk. And then your dissection, it has to be precise. You need a well-defined pocket, one that can accommodate the implant without too much tension or distortion. And then hemostasis, controlling that bleeding. That's key to prevent hematomas.
Makes sense. Are there any specific techniques or instruments that you find especially helpful during the procedure?
Well, when it comes to, keeping that implant pristine, that no-touch technique is really crucial.
Okay.
So you're handling the implant with sterile gloves or, special instruments just to avoid any direct contact with the skin.
Right. No contamination.
Exactly. And for irrigation, there's been some new thinking on povidone iodine. The FDA has updated its stance, and you can now irrigate both the pocket and the implant with it.
Okay. So that's good to know. Good update.
Yeah.
What about hypochlorous acid?
Oh, yeah.
I've heard about that being used as a potential irrigant.
It's interesting. It's a natural substance our white blood cells make, and it's got these powerful antimicrobial properties.
Okay.
And what's great is it's effective against a whole bunch of pathogens,
Yeah.
bacteria, viruses, the whole nine yards. And it doesn't harm those fibroblasts we need for wound healing. There's some research suggesting it might be less toxic to the tissues compared to, povidone iodine, but, more research is needed. We need to fully understand its role.
Sure. It's definitely a promising option. So let's talk about post-op care.
Right.
What are those key recommendations? Pain management, promoting healing, making sure that implant stings where it's supposed to be.
Right. Well, pain management is huge. Got to keep those patients comfortable. We usually recommend over-the-counter pain relievers, acetaminophen, ibuprofen, that sort of thing. And then for those patients with really tight pecs, those muscle relaxants like carisoprodol or diazepam can really help with the spasms and discomfort.
Okay, yeah. Those muscle spasms can be
Yeah.
pretty annoying. What about bras and dressings?
Yeah, so we usually recommend a supportive sports bra or a surgical bra for those first few weeks.
Okay.
Important to avoid underwire bras. They can put pressure on those incisions and maybe even move the implants out of place. As for dressings, it varies, but the goal is gentle compression, absorb any drainage.
And I know there's been some some debate about those implant displacement exercises,
Mhm.
after surgery.
Right.
What's your take on those?
Yeah, those involve basically massaging or moving the implants around.
Okay.
And the thought is that it helps them settle in and prevents capsular contracture. But the research is kind of mixed, you know.
Yeah.
Some surgeons think it might actually increase the risk of complications. So it's a bit of a gray area.
Okay, so maybe a case-by-case basis.
Yeah, I think so.
All right, so let's talk about complications. It's important we're aware of these, know how to handle them.
Absolutely.
What can go wrong?
Right. Well, breast augmentation is generally safe. It's successful. But complications do happen, and you got to be ready.
Yeah.
Capsular contracture, that's one of the most common and, honestly, one of the most challenging ones we see.
Yeah, capsular contracture. Big topic.
Yeah.
So let's start there.
Okay.
What causes it? What are the contributing factors?
It's basically the scar tissue capsule, right? The
Yeah.
one that forms naturally around the implant. It starts tightening, hardening.
Okay.
And the exact cause, it's, multifactorial. But things like subclinical infection, hypertrophic scarring, foreign body reaction, they all seem to play a role.
So it's a complex process.
It is.
Is there a way to, classify how severe that capsular contracture is?
Yeah, we use the Baker classification system.
Laker system, okay.
Yep, it grades the severity, from Baker First, which is a normal soft implant, all the way to Baker the First, which is, that's when you've got a painful, hard, distorted breast.
Not good.
Yeah.
So break it down for us. What are those Baker grades? What are those clinical findings?
Okay. Baker First, the breast feels soft, natural, no distortion.
Mhm.
Baker 30, it's a bit firm, but still looks natural. You might feel some firmness, palpate the implant, but no major distortion.
Okay.
Baker the Third, it's noticeably firm, might look a bit distorted. The implant's easy to feel, might feel hard. And then Baker the First, that's the worst one. Hard, painful, significantly distorted. You can see the implant feels rock hard.
Okay. So Baker the Fourth is the one we really want to avoid.
Absolutely.
Okay, so how do we manage this? If a patient comes in with capsular contracture, what's our approach? Does it vary depending on the Baker grade?
It does. It depends on how bad it is, and what their symptoms are. If it's mild, Baker through of third, we might just watch it. Okay. Sometimes, massage or ultrasound therapy might be an option, but the jury's still out on how effective those are.
Right.
But for moderate to severe cases, Baker the Third or Four, you're probably going to need surgery.
Okay. And what are those surgical options?
Well, capsulectomy, that's the gold standard. You're taking out the whole scar tissue capsule.
Okay.
And you might need to replace the implant, especially if it's damaged or, misshapen. And then there's open capsulotomy. That's where you make incisions in the capsule to release that contracture.
Okay.
But it does have a higher chance of coming back compared to capsulectomy.
Right. So capsulectomy is, I guess, the more definitive solution.
But in most cases, yes.
Okay. Are there any times when you would go with capsulotomy over capsulectomy?
Sometimes,
Uh-huh.
if it's just a small area and the capsule's thin, open capsulotomy might be okay. But closed capsulotomy, where you're just using pressure to break it, I try to avoid that.
Okay.
Too much risk of rupturing the implant, causing bleeding.
Right. That makes sense. Okay. So let's move on to another potential complication, leakage or rupture.
Okay.
Thankfully, rupture rates have gone down a lot with these newer implants.
Yeah, much better.
But what are those factors that can still cause a rupture?
Yeah.
And how do we diagnose it? How do we manage it?
You're right, the rates have improved a lot, but it can still happen. Could be anything from, a manufacturing defect to the shell just getting fatigued over time.
Mm-hmm.
Could be trauma, could be a surgical error.
Right.
Sometimes it's obvious, the breast shape changes or it feels different.
Yeah.
But other times it's more subtle.
So how do we catch those subtle cases?
Well, imaging is crucial if you suspect a rupture. Mammogram, ultrasound, MRI, they all have their place.
Okay.
MRI is the gold standard, though, especially for those intracapsular ruptures, where the gel is still contained within that scar tissue capsule.
Okay. So MRI is kind of the go-to for those tricky cases. And then once we confirm a rupture, what happens? What's the plan?
You got to act fast, prevent any further problems. You'll remove the implant, do a capsulotomy or capsulectomy.
Okay.
Whether you replace it, well, that depends. What does the patient want? How bad was the rupture? What's the tissue like?
Right. Lots of factors to consider.
Exactly.
Okay. So there are some other potential complications.
Yeah, there are.
Maybe we can just, touch on those briefly, just the key points.
All right. So you've got capsular calcifications.
Okay.
Those are calcium deposits in the scar tissue capsule.
Okay.
Sometimes you can feel them, or they show up on a mammogram.
Right.
Usually you just watch them, but if they're causing problems, you might have to remove them surgically. Then there's nipple sensation changes.
Mm-hmm.
Augmentation can affect sensation.
Okay.
Could be more sensitive, could be numb,
Mm.
usually temporary, but sometimes it's permanent. Hematoma, that's a collection of blood, presents as swelling and bruising. Small ones usually go away on their own, but big ones might need to be drained. Then there's infection, which is rare, but it can happen.
Mm.
Redness, swelling, pain, fever, those are the signs. Antibiotics, sometimes drainage. Asymmetry, well, perfect symmetry is tough.
Right.
But if it's really noticeable, it could be a problem with the placement, the pocket, the healing. Might need a revision surgery.
Okay.
And then you have migration and tissue changes.
Right.
The implant can move, which looks unnatural.
Yeah.
Or you get things like bottoming out, where it drops too low, or double bubble deformity.
Okay.
Those usually need surgery too.
Right. Okay, so before we move on to BIA-ALCL, let's just touch on cancer surveillance. Implants don't increase the risk of breast cancer,
Right.
but they can, I guess, complicate mammograms.
They can. They can make it a bit harder to see the tissue.
Yeah.
So you need those special views, like the Ickland view. And, the radiologist needs to know there's an implant in there so they can adjust their approach.
Yeah, absolutely. Communication is key. Okay, so the big one, the elephant in the room.
BIA-ALCL.
BIA-ALCL.
Yeah.
It's rare. It's serious.
It is.
Our listeners want to hear about it.
I bet they do.
So let's dig in.
So just how rare are we talking?
Yeah. And what do we know about what causes it?
Right. Well, first, it's important to emphasize that, yes, it's serious, but it is rare. As of, early 2020, the FDA had over 700 reports, and out of those, over 570 were confirmed cases worldwide. So
Yeah.
still a small number considering how many augmentations are done.
That's good to hear.
Yeah. And the median time to diagnosis is around 9 years.
Wow, 9 years. That's a long time after surgery.
It is. But some cases have shown up earlier. Now, the exact cause that's still being researched. But the leading theory is chronic inflammation. And the thinking is that it's potentially triggered by, those textured implants.
Okay, so chronic inflammation, what's the connection there?
Well, the idea is that the texture, on the surface of some implants, it can cause this prolonged inflammatory response in some people. And that chronic inflammation, that might be what creates the environment where BIA-LCL can develop.
So it's not the silicone itself, but the texture.
That's the thinking right now. But, not all textured implants are the same. Different companies, different techniques. Some textures might be more linked to BIA-ALCL than others. We need more research, really understand that connection between texture, inflammation, and how DIA-ALCL actually develops.
Definitely. More to learn. So what are the symptoms? What should we be looking for in our patients?
The most common one is a late onset seroma. And I mean late, often years after the surgery.
Okay, so that's something to really keep in mind. If you see a late onset seroma, take it seriously.
Absolutely. And along with that, you might see swelling, pain, redness, asymmetry, maybe a palpable mass around the implant. Those are all red flags.
So how do we go about diagnosing it then?
Okay, so if you suspect BIA-ALCL, you got to aspirate that fluid from the seroma. Send it for cytology. Look for any abnormal lymphocytes. And immunohistochemistry staining, for markers like CD30 and ALK1, that can help confirm the diagnosis.
Okay, and once it's confirmed, what's the treatment protocol?
Well, the main treatment is a complete capsulectomy. You're taking out the entire capsule, the scar tissue, everything, along with the implant itself.
Wow. That sounds pretty aggressive.
It is. But in some cases, you might need additional treatment like chemo or radiation. It really depends on the stage of the disease, how far it's progressed.
So is it usually effective?
The good news is, yeah, it is. BIA-ALCL is very treatable, especially if you catch it early. Most patients who have a complete capsulectomy, they do very well.
That's good. That's reassuring. But what about those patients who have textured implants, but they don't have any symptoms?
Yeah.
Should we be thinking about, taking those implants out just in case?
Yeah.
Prophylactically.
That's a tough one. There's no easy answer, and there's no consensus right now. It's really a case-by-case decision. You have to weigh the patient's risk factors, what type of implant they have, and, what they want.
Right. A personalized approach.
Exactly.
Okay, well, we've covered a lot today. A lot of information.
We have.
So let's recap. What are those key takeaways you want our listeners to remember?
Okay, well, we started by looking back, How have breast implants evolved? And the progress has been amazing, both in terms of technology and safety. We talked about choosing the right implant, that balance between patient wishes, their anatomy, understanding those risks and benefits. Then we got into the surgery itself, the technique, how important it is to be meticulous and follow those best practices to avoid complications. And then, of course, BIA, ALCL, making sure we know how to recognize it, diagnose it, and manage it.
It's a lot, but it's all essential for, anyone doing these procedures. So what's the final thought you want to leave our listeners with?
I think the big takeaway is, this field, it's always changing. We have to stay current, keep up with the research, the guidelines, the new technologies, and by combining that knowledge with, good surgical technique and a focus on patient safety, that's how we get those beautiful, natural-looking results and minimize those risks.
Absolutely. Couldn't have said it better myself. Well, as always, stay curious, keep diving deep. That's all for today's deep dive. We'll see you next time. So BIA-ALCL, it's rare, but it's serious. Our listeners want to hear about it.
I bet they do.
So let's dig in.
Okay, so just how rare are we talking?
Yeah, and what do we know about what causes it?
Right. Well, first, it's important to emphasize that, yes, it's serious, but it is rare. As of, early 2020, the FDA had over 700 reports, and out of those, over 570 were confirmed cases worldwide. So still a small number considering how many augmentations are done.
That's good to hear.
Yeah. And the median time to diagnosis is around 9 years.
Wow, 9 years. That's a long time after surgery.
It is. But some cases have shown up earlier. Now, the exact cause, that's still being researched. But the leading theory is chronic inflammation. And the thinking is that it's potentially triggered by, those textured implants.
Okay, so chronic inflammation. What's the connection there?
Well, the idea is that the texture, on the surface of some implants, it can cause this prolonged inflammatory response in some people. And that chronic inflammation, that might be what creates the environment where BIA-ALCL can develop.
So it's not the silicone itself, but the texture.
That's the thinking right now. But, not all textured implants are the same. Different companies, different techniques. Some textures might be more linked to BIA-ALCL than others. We need more research, really understand that connection between texture, inflammation, and how BIA-ALCL actually develops.
Definitely. More to learn. So what are the symptoms? What should we be looking for in our patients?
The most common one is a late onset seroma. And I mean late, often years after the surgery.
Okay, so that's something to really keep in mind. If you see a late onset seroma, take it seriously.
Absolutely. And along with that, you might see swelling, pain, redness, asymmetry, maybe a palpable mass around the implant. Those are all red flags.
So how do we go about diagnosing it then?
Okay, so if you suspect BIA-ALCL, you gotta aspirate that fluid from the seroma. Send it for cytology, look for any abnormal lymphocytes. And immunohistochemistry staining, for markers like CD30 and ALK1 that can help confirm the diagnosis.
Okay, and once it's confirmed, what's the treatment protocol?
Well, the main treatment is a complete capsulectomy. You're taking out the entire capsule, the scar tissue, everything, along with the implant itself.
Wow, that sounds pretty aggressive.
It is, but in some cases, you might need additional treatment like chemo or radiation. It really depends on the stage of the disease, how far it's progressed.
So is it usually effective?
The good news is, yeah, it is. BIA-ALCL is very treatable, especially if you catch it early. Most patients who have a complete capsulectomy, they do very well.
That's good. That's reassuring. But what about those patients who have textured implants, but they don't have any symptoms? Should we be thinking about, taking those implants out just in case, prophylactically?
That's a tough one. There's no easy answer, and there's no consensus right now. It's really a case-by-case decision. You have to weigh the patient's risk factors, what type of implant they have, and, what they want.
Right, a personalized approach.
Exactly.
Okay, well, we've covered a lot today, a lot of information.
We have.
So let's recap. What are those key takeaways you want our listeners to remember?
Okay, well, we started by looking back, how have breast implants evolved? And the progress has been amazing, both in terms of technology and safety. You talked about choosing the right implant, that balance between patient wishes, their anatomy, understanding those risks and benefits. Then we got into the surgery itself, the technique, how important it is to be meticulous and follow those best practices to avoid complications. And then, of course, BIA-ALCL, making sure we know how to recognize it, diagnose it, and manage it.
It's a lot, but it's all essential for, anyone doing these procedures.
Yeah.
So what's the final thought you want to leave our listeners with?
I think the big takeaway is, this field, it's always changing. We have to stay current, keep up with the research, the guidelines, the new technologies. And by combining that knowledge with, good surgical technique and a focus on patient safety, that's how we get those beautiful, natural-looking results and minimize those risks.
Absolutely. Couldn't have said it better myself.
Oh.
Well, as always, Stu, curious, keep diving deep. That's all for today's deep dive. We'll see you next time.